Top Med Talk.
So welcome to Top Med Talk at the Intensive Care Society State-of-the-Art Meeting 2018. I am your host and anchor, Desiree Chappell from the U.S., but we are here in the UK, in London, downtown, and I am with my co-host, editor-in-chief of Top Med Talk, Monty Mythen.
Hey Desiree, how are you this morning?
Good, I'm great, Monty. How are you?
Correction. I can actually see Big Ben covered in scaffolding there, and if I could actually see the clock, it should be good afternoon.
It is good afternoon. You're right. It was a late start today. Yep. Thank goodness. It's nice. I actually like starting a little bit later these meetings. For the first day, it gives you a nice little entree into a pretty intense 3 days, I would imagine, coming up here. Yep. Lots of great lectures, lots of great information. So, Monty, can you give us a little bit about, you said we can see Big Ben over here. We're looking at a big church. Is that...
That's called Westminster Abbey. That many people know from around the world. That's many of our very famous people are buried in the bottom of that, underneath. People like Winston Churchill, for example, I believe. But it's also many of the royal family get married, so some of you would have seen it on the TV around the world from that perspective. It's just over the road, which we can also see from the so-called Palace of Westminster, which is our Houses of Parliament. And at one end of it, although covered in scaffolding at the moment, is like the iconic Big Ben. Yeah. So we're right in the heart of London. Yeah,
the center of it all, having this amazing meeting already.
We're actually at the Queen. This is named after Queen Elizabeth II, our wonderful
That's right,
Queen.
The center.
It's the Queen Elizabeth II Conference Centre, and right next to it is the Methodist Central Hall, which is where we had the opening plenary session.
That's right. Actually, this is a very modern building, so the juxtaposed and all this very ancient type of architecture is pretty cool, gorgeous. So, Monty, you're able to get to the first session early today.
Well, it's the Intensive Care Society State-of-the-Art meeting, as you said, which has been...
Give us a little history about this.
It's a long-established meeting. First,
you've had some experience.
I remember some of the first few meetings led by Dr. Neil Sony, one of my mentors out in West London, and over the years it's had a rocky course at times, but more recently it's been reinvigorated into this absolutely wonderful meeting. Now, it was great before, but it's become truly multidisciplinary now. It's one of the big things that's brought it forward. And I believe here today there's about 1,500 registered delegates, which is great. The plenary session in Methodist Hall, which is a big old place you saw when you came in. That's a forum to be proud of. It was packed, which was great. So really exciting.
Yeah, it's fantastic. Well, some of the speakers, we've talked a little bit about some of the first plenaries this morning.
So a really interesting potpourri in the first session. We had a welcome first by Gary Masterson, who's the ICS president, and Steve Matthew, the ICS program director, and a big shout out to them and all the team for putting this all on, as they highlighted at the beginning, but quite rightfully, they've worked really, really, really hard to bring this home. It's something to be extremely proud of. And then we had quite a punchy set of presentations. We heard first from Hayley Prescott telling us about the microbiome. Then we had a little bit of a fun session between Simon Finfra, who works in Australia, and Mervyn Singer, and it was entitled Sepsis the Ashes. Then Brian Cuthbertson, who is he's from Great Britain, he's actually from Scotland. Have you heard of Scotland?
I did.
Scotland working in Canada, so he had some reflections on how we could make Britain great again. Then Esther Murray told us about moral injury, which more related to physicians being exposed to traumatic episodes clinically, but the thing that really stole the show at the end of it was entitled From Russia with Love, with James Haslam and Steve Emmett. And we'll go over the others, but we'll probably come back to that. It was a highly emotional session that resulted in a standing ovation and some of the longest applause in a scientific meeting I've heard for a very long time.
Yeah, I was going to say, how many standing ovations and something like that have you seen before? Probably not too many.
Not too many.
It was very emotional. So tell me a little bit, because I'm interested in the microbiome and in the critical care setting. So what did Hallie have to say? Any take-home points from...
Well, there's a few, catchphrases. I mean, I think we're all learning about the microbiome again. It's become fashionable. Fashionable right at the moment is the bugs, the microorganisms that live within us symbiotically, and that can vary quite a lot. It's now being badged as the forgotten organ of multiple organ failure. Now, interestingly, when I started my research 30 years ago, we were talking about the fact that the gut was the motor of multiple organ failure and the gut was the forgotten organ of. But that was much more at that stage about perfusion of the gut and the gut becoming leaky. This is much more back to that idea that if you are a yogurt eater, if you eat probiotics, the idea that gut health and the bugs that live within your GI tract and therefore populate your body, your skin and everywhere else make up such a large bulk of your symbiotic collective organism that they're an important part of health. And she presented very compelling research that is so. The associations with having an abnormal microbiome called, for those of you who want all the buzz phrases that make you sound cool, it's dysbiosis. And if you have a bad version of it, it's extreme dysbiosis, which can be almost complete depletion of your gut microbiome, which I think is like 12 pints and a curry for those of you listening.
I would think that would add to the...
That's maybe not a good example. But
well, are they saying that there's contribution to disruption of the microbiome because of the antibiotics and things that we're giving? Or that people are coming in to us this way and that's part of their problem?
I mean, if you look down the list, half of the things that seem to disrupt your microbiome go with being sick.
Right.
So abnormal perfusion of the gut and all of that. The other half seems to go predominantly with what we do to people.
Yeah.
So the necessary evil of the administration of antibiotics, in particular broad-spectrum antibiotics, really upsets the microbiome. Yeah. And then the unnecessary administration of poorly targeted antibiotics and or leaving them too long really puts the boot in.
So what is she saying about treating it then? I mean, are we trying to replace these with probiotic, prebiotics, these things in the ICU? Is that a movement?
I think we could all think of things to do.
Yeah.
And in animal models, those sorts of things we might choose to do, the data's looking interesting, really interesting, both mechanistically and from the point of view of survival short-term studies in rodents, for example. When you start to move into humans, the early work is also looking interestingly, and broadly speaking, from what I saw presented, and I'm absolutely no expert here, although I do have a little bit of research experience in it, is that you either the idea of probiotics, so to take a bottle of something, let's call it a super yogurt, that's underplaying what it is, to restore your microbiome, to correct your dysbiosis is one angle. But the other slightly more challenging one to think about is the so-called fecal transplant. Now, we didn't go into the details of how one does a fecal transplant. It might be worth looking up online.
I'm participating. I haven't received one.
You've received one?
I've worked in endoscopy where we've done fecal transplants.
Okay. Well, maybe you could talk us through it. What did you do?
It's nothing special.
Okay.
I mean, you can imagine what it is.
But I was also reflecting that your kids out there doing unintended fecal transplants
every day.
Playing in the yard.
I actually have experience probably myself from my children. Too much information.
All worth looking up. There's also relatively recent, published in Nature in 2017, a trial of symbiotic in children in, I think it was in India, for example, with very, very compelling results suggesting improvement in survival. So definitely an area to keep a close eye on.
Not to belabor this, because but was there a study about sepsis and probiotics and issues? Was it in children?
Yep. That was the one. That was what I was referring to.
I thought that was a negative effect, though.
Oh no, the negative effects were not necessarily, as far as I understood it, again from the way it was presented. So some of the negative results that have come through has been possibly the mode of delivery of the agent. So in one of the pancreatic studies, for example, it was a jejunal feeding study with quite a high fibre content. And there's already some suggestions that subpyloric feeding and overfeeding in certain patient groups. So it's a slightly confused message, that one. But there was definitely a health warning to say don't assume that that probiotic treatments in whatever guise are necessarily safe and benign, because if they have a good effect, they almost definitely have a potential for a side effect.
Sure. Okay. So moving on to... do we cover all that one?
Yeah, that's great.
Got it all
That's
covered.
all I know about it, and I know nothing.
Well, I was going to say, vegans
I
actually have a really great microbiome. Because all they eat are vegetables, and that's what feeds it. So.
And you have to go off eating off other people's plates because there's never enough.
That never happens.
But hopefully we'll catch up with all these people and interview them directly. If not, there's some other fantastic social media work going on here and interviews going on around us from the amazing Intensive Care Society team who are already getting interviews in the bag.
Yeah. That's awesome. So the next one was sepsis and the ashes.
Yeah, so Simon Finfer, as I said, he's an ex-Brit again, went to work down in Sydney. Him and Mythen Singer were really exploring this literature that suggests that outcomes from sepsis in particular might be far better in Australia or Australasia than they are in the United Kingdom. So I'm not going to get into the detail of that, but they gave that a good going over, and as always, very entertaining, very humorous from both of them. There was some... do you know what the ashes are, by the way?
That's what I was going to ask you.
No,
Can you explain this title a little bit more?
It's a game of cricket. Do you get that? That's like baseball, but goes on for longer.
I played cricket before.
Okay, you have played cricket, actually, very true.
Yeah.
So cricket and Australia, England, the trophy, which is about so big, tiny. I'm just sort of holding up my finger and thumb here. It's about so big.
Yeah.
Which is an iconic trophy, allegedly contains within it the ashes of the piece of stick. You remember the bales that went on the wicket thing?
I got that. Remember
that were burned after the first game and put in this little urn to represent the death of one side or the other whenever it happened. So they play for that on a regular basis, and those of us who are interested in cricket, it's a big deal. Okay?
Oh, gotcha.
So Australia versus England, they play for the ashes, and we think it's the biggest game of cricket in the world.
All right, so this makes sense now.
Right, so they were reflecting on this suggestion, the fact that there's a difference in outcome from sepsis in Australia compared to the United Kingdom. And I said, I'm not going to go into the details, but very well considered reasons why it may not be as simple as it looks. It may relate to staffing models, it may relate to remuneration models, it may relate to availability of intensive care unit beds, it may relate to just superior practice. But, well tried, tested, and I hope we grab both of those characters, as I call them, later on to discuss them. Yeah, Simon representing Australia, where he lives and works now.
Gotcha.
Simon Finfer, and has done for a considerable period of time. And Mythen Singer is one of my colleagues from University College London.
Oh, gotcha. All right. And then moving on to the next session, or to the next presentation, Making Britain Great Again, which this kind of cut a little bit deep for me.
Well, I think that Brian Cuthbertson, who I said is one of our colleagues from the United Kingdom who's gone more recently to go and work in Canada, is an extremely well-known clinical trialist leading many of the large clinical trials, was reflecting particularly on two trials that were supposed to answer the same question, that related to the use of oscillators in intensive care unit patients.
Yeah.
And these two trials are extremely well known because although in the two trials the control group, for one of them done over in the UK, one of them done over in Canada, the control group mortality was the same in both countries. Mm-hmm. The intervention, which was oscillation as a form of ventilation, went in opposite directions.
Yeah.
So in one country things got worse, and the other country things got better, which led him to explore, is there really a difference?
Yeah.
And again, cutting a long story short, his conclusion was that we're just not very good rule followers here in the UK. So our adherence to the ventilation protocol was such that we were all over the place from the delivery of the therapeutic intervention.
Yeah.
Now, in Canada, and we didn't have a chance to go into it, and hopefully we'll catch up with Brian and explore this, I think they may use respiratory technicians in Canada as they do in the USA. Because you do in the USA,
just going to ask, so that doesn't happen here.
It does not happen here. So here,
you go make your own ventilators.
The setting of the ventilator is done by either the intensive care unit nurse and or the doctor, and sometimes the physiotherapist. But it's not a job for an independent professional to examine and change that the whole time. So we believe, as part of our practice, our Maverick style practice in intensive care, either that we don't think it makes that much difference, or we're really, really good at it. And I think it's very important to put the PEEP here and to put the volumes there and to stand there and twiddle with the knobs for ages. Whereas when I worked in the US, somebody else came round and did that against the protocol. So I think Brian's conclusion was that our Maverick style practices, our belief in autonomy of the physician, independent of the evidence base, is possibly driving some of the poorer outcomes, and he thinks that we should get a grip on that. And I tend to agree with him.
Yeah, I mean, the variability that you have of all, if anybody can walk into the room and make adjustments at any time.
We think it's an important part of what we do. So,
interesting.
Interesting, good challenge there.
Yeah. Some good lessons to be learned. And then moving on to Esther Murray, she gave an interesting presentation on moral injury and really dealing with the trauma of working in the ICU and critical care setting where it can be really stressful.
Yeah, so another great talk, very compelling.
Yeah.
She brought in some basic science that related to empathy, for example, and our response as practitioners to the model she was using was referring to seeing pain injury and the suggestion that different parts of the brain do and don't light up in physicians and non-physicians, and started to explore the suggestion that we possibly with chronic exposure over time become desensitized, but then challenge that as well to say that that's too simplistic an explanation. It's just been very mindful that everyone can be exposed to moral injury. One way we recognise moral injury is post-traumatic stress disorder in people who've been into battlefields, etc. But perhaps it's happening around us, though, on a regular basis, and we should be particularly sensitive to the people earlier on in their career who are being exposed to injury and traumatic acts.
And she was not a critical care physician.
No, she's a specialist from her area, exactly. So, doing research in London. On that specific area in one of the places where they have one of our large trauma units. So
I thought it was interesting. I thought it was just my own personal experience working in critical care and as a young nurse. Nurses go through the same thing as physicians. It can be that traumatic, but it was a great presentation. And then actually, somewhat interesting that it came right before the last presentation, which was From Russia with Love by James Haslam and Steve Emmett. And Monty, we talked a little bit about this. It was a very emotionally, just a very emotional presentation. So can you give us a little bit?
Yeah, so James is a frontline critical care physician in one of our hospitals in London. People can start to work it out as we start to reveal the story. They asked us to be discreet about this, but to a point, because this story is extremely well known in the global press. There's a clue in the title about the From Russia with Love. Some people exposed to organophosphate poisoning in the United Kingdom, who were admitted to, I think by the way they described it, a district general hospital. I don't know what they call it, a general hospital.
Yeah, community facility.
Admitted to it. Initially 2 people. I say this is extremely well known in the popular press, but we've agreed to be very light touch with the detail of this, who were very, very unwell in an unusual way. They were found deeply unconscious in an area that's very well known for people doing recreational drugs. But as it evolved over the hours that followed, it was very unusual, and on the differential diagnosis, possible poisoning rose up the list quite quickly. I say again, without going into all the details, a true, and there was a third person that was subsequently exposed and poisoned as well. A real tribute to teamwork, to resilience, to not giving up under any circumstance, to resorting to basic physiology and pharmacology, which is often criticised this day and age, where people say you've got to just go by large, pragmatic, randomised, multi-centre trials. This success story, because all 3 survived, was driven by not giving up, by caring, and to going back to basics. They worked out the cause of it by collaboration, by bringing in national agencies. They worked out the right treatments to apply based on historical writings and then reconsidering the basic physiology and pharmacology. They found some experts to help, and all 3 survived. But you could see from the presentation, highly, highly emotional. Well done. Well done that man, well done that team for getting through that. And hence the huge round of applause that seemed to go on forever, which is quite right. Followed by, again, a standing ovation at the end of it. Well done.
It was, absolutely. I didn't actually know what the presentation was going to be about. So whenever I heard it was just jaw-dropping, really, the entire situation. And for everything that the team went through, those people survived because of the great teamwork and collaboration by all. It's still emotional. But on that note, I think that it's foreshadowing of some really interesting topics to come throughout the rest of the meeting. Lots to look forward to. Monty, is there anything in particular as you had glanced through the schedule that you're excited to hear about?
Yeah, I really want to go to the nutrition session I think it's this afternoon.
It is.
I think they're going to get into the protein question in particular.
Yeah.
It's chaired by
Ella,
and Danny. And we're going to hear from Emma Ridley. We're going to hear from Olaf. We're going to hear from Zudin. All extremely well known. We're going to go through the science behind the energy intake recommendations. We're going to consider the protein side of it, and Zudin's is going to be very challenging about patients don't give a monkeys about intake. Utilization is king. So I'm really looking forward to that, because this idea that when you're critically ill, if maybe you're doing something that's a bit like hibernating to survive. Is that actually you can put as much food as you want in the body, but if the cells aren't going to use it, it's just a waste of time. So I'm really looking forward to that.
All right.
And I'm ashamed I'm missing the cardiogenic shock session.
Yeah.
Because it's, and I hope you get a chance to go to that.
I know. I was thinking about actually heading over that way to look at echo, utilizing echo in the ICU, which I think is a little bit different than whatever. I remember. Well,
I think they're also, because we've become so obsessed with the management of sepsis in recent years, which has all been about the appropriate use of vasopressors, noradrenaline, perhaps vasopressin in particular. I think this session, which is titled "Are We Failing the Failing Heart?" is saying, hang on a second, don't forget the fact that there's hemorrhagic shock and there's cardiogenic shock. And don't treat everything as though it's sepsis, and don't treat everything with norepinephrine. So I'd love to be in there, but I'm actually going to go into the nutrition one, so I hope we can tempt you to go to that one as well.
Yeah. I'd like to hit that. And then later this afternoon, we can talk a little bit about the maternal critical care. Actually, it's something I'm really interested in checking out, and some things on global health.
This is a global health bit, so we've got in here the famous Van Tulleken twins. So Xand and Chris Van Tulleken are TB celebrities.
Really?
Yeah. Good-looking boys.
All right. Well, maybe I'll have to hit that session.
They are twins. They're really interesting. They've been on some of the Everest expeditions with us. They went on the Choyoyu expedition leading up to the Everest expedition. I was lucky enough to sit with them in a dinner at one of the celebratory things with my wife Kate, and she didn't talk to me all evening.
Oh, don't feel bad, Monty. I'm sure they're just very entertaining.
But that will be fun as well.
Yeah. All right. Well, we are going to wrap up for this, and then hopefully we'll catch back up after the next session. We can go over some and hopefully catch up with some of the speakers and get them sitting down or participating in some of the other things that are going on here at the Intensive Care Society state-of-the-art meeting at here in London.
Thanks a lot, Desiree.
All right, cheers.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.